How's it going, guys? So this is Dr. Suh. I'm a Gonstead Chiropractor and providing Gonstead Chiropractic, Manhattan, New York City. So we have a special guest over here. Fill us in. What can I do for you, sir?
I need help for my knee.
Okay, what's going on with that knee?
I have pain in the knee. The knee is I can't pull straight.
You can't make it straight. Okay.
Yeah.
So, yeah, we can see over here, you can't fully extend the knee. What else is going on? Okay, what else is going on? Do you have any troubles going upstairs or downstairs? Which is most tougher for you?
Downstairs.
Going downstairs?
Yes.
And you cannot put, it looks like, obviously with this cane over here, you have a lot of trouble putting weight on this thing? Correct?
Yeah.
All right. Can you do a squat for me, or is that too much?
It's too much.
Can you go like this a little bit? Can you?
No, I have pain only over there.
Okay. All right. Okay. Sit down. I don't want you to fall. Okay, go ahead. Sit down. All right. So what we're gonna do is this. We're gonna take a look, see what's going on with this knee, and then take it from there. Starting off with instrumentation, and we're looking for any abnormal temperature initiated by inflammation. So when the tissue gets damaged, it initiates that inflammatory process, causes the blood vessels to enlarge, and resulting in increased heat. This device picks that up. So we're marking any potential areas of concerns that we want to take a closer look at. Now, it doesn't necessarily mean this is definitely the problem areas, no. These are only components of objective data we're looking for to help us focus on these key areas. There you are, you're hiding right there. Alright, so I'm already seeing that this knee is able to rotate and pivot just fine. This is not rotating whatsoever. And it looks like it has more trouble, it's easy to rotate this way, but it has trouble rotating back that way. Okay. Now, upon that gait analysis, what you guys saw earlier, what I'm already considering is that, okay, we had to check the nerve integrity, what's going on from the motor cortex, flowing all the way straight down to the spine itself. So if there's any potential traffic jams along the way, it's going to slow down that nerve information. And remember, it's a two-way highway, so there's information, commands. There has to be motor cortex that commands the knees what to do, going down to the knee itself, and then there has to be feedback information from the knees, had to go back up this highway into the motor cortex and cerebellum again. So therefore, we want to ensure that the two-way highway is nice and clear and not too much traffic jams along the way. So usually it's this fourth lumbar region that deals with the knee innervation. However, just looking at the x-ray over here, what I'm doing is I'm overlapping the mainframe idea of the x-rays, and this person has one extra bone. So now I'm going to double check, see, are we doing a fifth lumbar nerve involvement for the knees or fourth lumbar nerve involvement? So now I'm overlapping the data with that x-ray, and I'm now checking everything over here. We're clearing out the foundation. I don't see any edema, and I don't feel any edema. I'm also checking, all the segments, everything is pivoting just fine. And there's nothing in there. Now we're checking this, sixth lumbar, no problem. Fifth, how do you like that, sir? Pain there, huh? Yeah. So fifth lumbar, that's in trouble. And there's puffiness, there's swelling, there's edema all around this area. Now we check the fourth. How's that?
Pain.
Pain. Which was worse, the one bottom or the one top? Top. Interesting, because the fourth, the fifth lumbar, that ain't moving. See that? That's jammed up. And on top of that, I see in the x-ray, that's where the DJD is as well. So let's check everything else. And one motion part, I'm mostly feeling for the edema as well. So this one, some edema right there. So got a potential one. But the other thing is this, I'm also remembering what is the fixation feels like. This is a partial fixation. That tells me that biomechanically speaking, because the instability over here, okay, is leading up to a compensation that's steadily turning into a subluxation. So this one, I'm anticipating after we address the one bottom over here, this one should start calming down. Now, another thing I'm seeing on the x-ray over here while I'm analyzing is what's going on with that one heck of inferiority on that fourth cervical over there. And you can see over here what kind of biomechanical stability. There's this thing over here, the upper dorsal is bulging considerably, and then we see all the muscle spasm tightening already he's looking at. See, there's a little muscle spasm here. So it's soft over here and swelling over here. So therefore, let's check, 6, 5. How's that, sir? Tender?
Yeah.
See, fourth cervical, that's in trouble right there. So this one's even more key and important because that's basically like the first major traffic jam along the way. Sort of like saying like, okay, this is a GW over here, which is a major, gateway into New York City. So if we had that fella, heavy traffic jams over here, I expect all that information from the cerebellum and the motor cortex go to that knee. It's gonna have a lot of trouble doing so. All right. So yeah, that's that fourth cervical. We're gonna mark it right there. All right, so here's the story. As I explained before, so we have the motor cortex right over there. We also have the cerebellum over here. This is the brain over here. And as I explained before, this is like the 495. We need to have the information, a two-way highway, go straight down here into the knees. All right. Now, we already found some potential issues. We have already found, okay, we've got a traffic jam here. We got a partial traffic jam here, and we definitely got one at the fourth cervical. So that being said, okay, this thing needs to flow like this, and it does so in milliseconds. Rapid fire, two-way street. Once again, the motor cortex commands the knees. It says, okay, the knees, keep in mind, it's one of the most unstable structures unstable joints in the human body. Why? Because it's basically like two flat pieces of paper. It's not like a shoulder or a finger joints where it's just like this, where it's a pivoting joint like this. It's not. The knee is almost like completely flat over here. So what holds it in place? Well, just like cables, right, that tells it, says, okay, you're going too much this way or that way, or that way. Those cables, AKA ligaments, okay, that's what keeps it in place. So we have the ACL, PCL, medial and lateral collateral ligaments, meaning they try to keep that knee stable and in alignment as much as possible. What tells it to do so? Well, here's the thing. We're not under conscious thought, meaning it says, oh, okay, knee, go this way or go that way, left, right, back, forward. We have no control over that. It's control from these two fellows over here. That's what commands the ligament. Says, okay, fellas, so every time you take a step, it says, oh, you're going too much this way. Okay, let's strengthen up the ligaments. Let's try to go back this way. You should go this way. Okay, muscles and ligaments. Let's pull it back. Try to go back to this way over here, right? However, because we had that kind of slowdown, it's not getting that proper relay information. So the brain is telling the knees do this way, but it's not getting fast enough back in the brain, and then we have that miscommunication. It's not reacting as fast, and it's getting looser and looser and looser over time. All it takes is a trauma, which you explained to us in the consultation. You fell 15 years ago, and ever since then on, you've been having that knee problem, right? Yeah. So now what we're going to do is this. We're going to clear up these traffic jams, get more information into these knees, and get this knee working even better before we start adjusting that knee. As I alluded to before, you actually have one extra bone. Normal is 5 lumbars, but you actually have a 6th lumbar, right? And part of the deal is trying to become part of the sacrum. Now, here's the thing. Because it's unstable over here, that's where this 5th lumbar over here starts to degenerate. I want to see a nice healthy this size, like this fellow over here, but nope. This fellow over here, no, it's shrinking quite a bit. In addition to, because you have an extra bone, either you may have an extra set of nerves or you don't. I don't know. okay? Because everyone's wired differently. So that's why we need to map things out and really see how things come along. Now, in addition to another thing, as I mentioned earlier, that for cervical, right, is very inferior. Normal, we should have a normal arc like this. We don't. This fellow over here, all intents and purposes, so it kicked out like this. So therefore, the spinal cord, the brain stem's over here, and then the spinal cord got to go through this highway over here, through this tunnel. But we have a choke point right at that tunnel spot, right over there. It's irritating the nerves over here. Therefore, we're not going to have too much information going out there. It's sort of like having a major traffic jam within the Holland Tunnel itself. All right, so we got to clear that fellow up. Now, in terms of your knee, okay. Now the good news I'll tell you is that while yes, you have some arthritis, but it's not severe enough. We're talking about, I don't want to see bone on bone. We don't have that, so that's a great thing. However, what I am seeing is, this is your kneecap over here. Normal, I want to see the kneecap right in the middle. See this one over here? I want to see it right in the middle between these spots over here. They're not. So what causes the kneecaps to go on the outside? That's what we were talking about before. For the average person, the fourth lumbar nerve controls these innervations. But since it doesn't have that innervation, as in it doesn't have that massive traffic jam, the VMO, vastus medialis oblique muscles, are responsible for keeping the patellas, the kneecaps, in the center line. But since it doesn't have enough nerve function to this muscle over here, the VMOs, it cannot hold the kneecaps in place. So therefore, since these muscles over here are working fine, the kneecaps, they're going to go out that way. So we got to restore the nerve function to the VMOs over here so the kneecaps can go back in center alignment. In addition to, I saw how you're walking. This knee over here, I want to see it moving and pivoting like this, okay? Your knee is slightly going like this, but it wasn't going this way at all. And that's what I confirmed it over here in the x-ray as well. You know, you have an AEX knee over here. So we got to address this. So in other words, you're stuck this way, right? So yeah, since it's been over 15 years old, I'm not making any promises, but we're going to see what we can do. We're going to gently realign that fella and see what kind of improvements we can get out of that fella. Relax, a little more. Okay, come on up. Okay, go ahead, walk around. Wow. Let's raise your pants a little bit. Yeah, go ahead. Walk around.
Yeah, because the pain is over there. They continue the pain.
So what's going on? Fill us in, because before you had some trouble walking. What's different now?
Even it's more good to walk, more strong.
How much stronger would you say?
It's 50%.
50%. Hey, how do you like that? That swelling is already going down. Yeah, it's moving. See, how's that? Not bad, right?
Yeah, no.
Yeah. See, now we're checking this mid-dorsal here. Hey, how do you like that? That disappeared. No problem. Good. That's what I figured. Okay, relax. Yeah, see, even this bulge over here is starting to calm down a bit. It's not as protruding as much. See, this fourth cervical is still in trouble. All right, we gotta correct this. So because of the nature of this inferiority, while yes, it's more ideal to do the cervical chair, but actually biomechanically, what I'm looking at, and to really reset it real deep, and gotta clear up that traffic jam really quick. Now we're gonna do the knee chest. This needs to be done prone. Here's that fourth cervical. Now the reason why I had to switch from the knee chest to the high-low table is because of this. Less shoulders. So because of this, it wasn't able to relax. We cannot get the inferiority, but this one now. Relax. Well, there Go ahead, start walking. Okay, my friend. Tell us, what's different about that knee now?
It's more better.
How much better would you say? You told us last time, 50% improvement. How's it now?
I think so. It's 70.
70%.
5%.
Yeah, I like that. So just as we discussed before, we cleared up that traffic jam right there. See, that's why it's so important to make sure for chiropractic, our job is not just pain relief. Our actual real primary job is restore nerve function. So make sure everything's communicating properly from the brain to all the tissues. In your case, we need to have proper function from the brain onto that knee. All right, now let's go ahead. Now let's finally take a look at that knee itself. I know, it's been here for 15 years. We're gonna set this. I know, we're gonna pump it first, and then we're gonna set it. I know. I know. Just breathe. I know. It's been there for a long time. And how do you let that? Now it's moving. Okay, whenever you're ready, come on up, sir. Okay. Fill us in. How's that knee now?
Now it's more strong.
More stronger?
Yeah, more stronger.
Okay, so you said 70% before. How's it now?
Now I think so. It's 90%.
90% better.
Yeah.
Hey.
Because the inflammation is can pull a strike.
All right. Hey, that's great progress right over there. So here's what I want you to do. I want you to continue icing over here. Because see this? This is swollen over here. Okay? That's edema. There's also a lot of edema on the back. So a lot of swelling over here. So ice over here, 20 minutes, 3 times a day. And I'll see you in the next visit.
All right.
All right?
All right.
How are things overall with that knee?
I feel it's very good to now.
Okay,
to walk. It's no. The last time is don't can walk better. Now I can will walk better. No problem.
Yeah, we all can see that. You're not using a cane anymore, and you're walking much easier without it.
Yeah.
So how much better would you say, walking wise?
I think so. Now is 1%.
Say again?
100%.
100%. Yeah.
Yes.
Okay, that's good. Small reading there. You still have that fourth cervical problem.
I copy that.
Right there. All right. That thing is still in trouble, but.
Yes, copy.
Right there. Usual spot. Fourth cervical. There it is. Come on up. Walk around.
It's good. The work is good. Yeah, that's what I'm saying.
There we go. It's pivoting more.
Yeah.
There's that beauty. Come on up. Walk around.
it's good. Walk is good. Now I don't feel the pain over here.
Yeah, see, that's what we're talking about before. And that's what we see as well. Now this knees, now it's moving back and forth. It's pivoting just fine. That's what we talked about before. You need more nerve function going down to the knee over there. Yeah. See? You got almost 4 range of motion in that knee. All right. Just relax a little more. We're gonna set this knee. Just relax. There it is. Good. Okay, walk around.
Oh, it's good.
There you go. Yeah, how do you like that now?
Yeah. That's what. One is good.
All right. So give us latest updates now. But
Let me try.
some feedback.
Oh, yeah, no.
How's it now?
It's good. Now it's good.
See, that's what the story is going to be, all right? So we started our pathway to start stabilizing spine. Those are the key components. We're going to keep consistently work on this fourth cervical over here and your fifth lumbar vertebrae. Get both of these two major traffic jams out of the way and get more nerves working into that right knee of yours. We're going to keep on doing that up, and then we'll see you next time. Right? All right, that's all it takes. Enjoy that knee. Have a good one.
Thank you.
Oh, you're very welcome.
Yeah, this is good, very good.